And I'm Dr. Clark. I'm one of the cardiology fellows here at Riverside. And today we are going to review some EKGs. I think the goal out of this is that you guys improve your skills as far as rhythm recognition and then recognizing some of the emergent things that you need to address quickly. So let's get going. First of all, disclosures. I don't have any. I'm not making money really, so it's kind of easy not to have disclosures. But I wanted to take this slide to make it the point that the things that you've learned to this point, hopefully they're all accurate. The things I present to you, I hope are accurate. But I think everything you learn, you should, kind of trust but verify. So if I say something incorrectly, it's very possible. But there's ways you can look that up, and hopefully you'll find reliable sources to do so. Some of those sources that I would recommend from an EKG perspective, we will get to. But first of all, the objectives. So I want you to obtain a better understanding of the normal cardiac conduction system. Recognize conduction abnormalities, recognize AV block, and recognize ST elevation and what territory might be affected. We're going to start with the very basics of the cardiac conduction system, and I'm hoping that as we progress through that, you guys will gain a level of understanding before we move on to the next part. I am going to record this so that, and hopefully later put it on YouTube for you guys, so that you guys can come back to it. I've done a few talks with nurses and paramedics before, and sometimes I get blank stares at the end. And so I hope that you'll be able to come back and reference this. And so if there's something that you miss, maybe you can use that to kind of brush up and see what kind of deficits you might have. Some of the things might kind of go beyond your scope because we have different people here today. So you can ignore those things if you would like. Some of you might have more interest in EKGs than others, and rhythm strip recognition, and so you might want to dig a little deeper than what we go today. So I will try to keep it to the level of kind of what is acceptable. But I guess I'll do my best. Resources. I found these to be very useful. This is not an extensive list by any means, but if you're starting out and you have an interest in EKGs, this is Dubin, Dale Dubin, Rapid Interpretation of EKGs. This is a good place to start. It takes a very basic approach to understanding how an EKG works, and we'll use some of those ideas in this talk. ECG Workout. This is a book that I feel like is a very quick read to get through it, and has some good references in there and some basic ideas. If you want to get more advanced, you could do the complete guide to ECGs. Basically, everything you would come across on an ECG should be in that book for the most part. That's why it's complete. This is probably the best reference, though, that I would refer to. This is a guy, I believe out of Australia, a doc, actually an ER doc, who started the website as a reference for people. And I have found it to be very useful in that, if you go to a book, you're going to take some time paging through to figure out what you're looking for. But that's a very quick reference, and from the times I've used it, I found things in an efficient way, and it's the answer you're looking for. So it's a good place to go. All right, the conduction system. So it's one of my preferred slides to look at the anatomy of the conduction system. So we have to recognize, first of all, that normal impulses start at the SA node, and they propagate in a wave. If any of you have had the opportunity to see an electrophysiology study with 3D mapping, basically we stick catheters into the heart, and we generate with a lot of very advanced technical equipment and software. We generate a 3D map of the conduction system, and so you can see an impulse that starts at the SA node, and it propagates in a wave across the atrium from right to left, and then also top to bottom. And it goes down to the AV node, where it slows conduction in the AV node, right? And from there down the His-Purkinje system very rapidly to the ventricles. And from there, within the ventricles, it propagates again as a wave through the ventricles. And so that's essentially what makes up the EKG. That's what we're looking at. We're looking at that wave of propagation through the heart. The P wave representing the atria, and the QRS representing the ventricles, and the T wave, the repolarization of ventricles. And we'll get into that more deeply, but you definitely have to have an understanding of the anatomy, I think, before you can go further. So this is the right atrium. This is where the sinus node sits. This is your superior vena cava, and your inferior vena cava comes from the bottom here, and it fills blood into the right atrium. The blood then goes into the right ventricle through the tricuspid valve. It can exit the right ventricle out of the pulmonic valve and go to the lungs. Right? Blood is going to come back to the left side into the left atrium through the pulmonary veins. It's going to go through the mitral valve into the left ventricle, from the left ventricle out of the aorta to the body. So it's basic flow of blood. What we're interested in, though, is not how the blood flows. We're interested in how the electrical signal progresses through the heart. And different disease entities can cause a change in that electrical signal. So that's kind of what we're going to talk about today. So this is EKG number 1. The first part of the talk has a lot of illustrations and not as many EKGs, and I figured if we get through that successfully and you guys all have a reasonable understanding, then we'll go on to just kind of do cases and EKGs. So first of all, I'm not going to call anybody out, but you want to get a general understanding of what's going on. So the rhythm strip often gives you a good idea of that. And so here you see sinus rhythm. I guess what I want to ask you with this is, does anybody tell me what the pulse rate is? And we'll do polling. And so I'm going to say, is the pulse rate 200? Is the pulse rate 75? Is the pulse rate 30? Or you can't be sure? 75. Anybody else? So this is the point I want to make here is the difference between the electrical stimulation of the heart and the mechanical response. Right? So just because you have an electrical stimulus doesn't mean you have a mechanical response to produce a pulse. So based on this, you can't be 100% sure that the pulse rate is 75. The rate, you read correctly that the rate of the QRS complexes does come at 75. So you could say probably within almost 100% certainty that this patient's pulse rate is 75. But my point is, this could be PEA as well, right? And so you can have the electrical stimulus, but if you don't have the response, then you're not going to have a pulse. So you have to understand that. Here's the first EKG. This is Eindhoven, and just kind of take you back to the basics of it, I hope. This is not too basic, but he's got his leg in some saline solution, and he has both arms in saline solution. And so what he's checking is the electrical difference, between those things. And that is the basis for what we get now. And so when we talk about what produces this signal, we're talking about ions moving across membranes, right? So within the heart muscle itself, you have myocytes, or the myocardial cells that make up the heart. And within those cells, the membranes, there's a potential across those membranes, and it's created by the movement of sodium, potassium, chloride, calcium. And as these ions move across the membranes, that's what leads to depolarization, and that propagates from cell to cell throughout the heart, right? So this is a general understanding you have to have, that at baseline you have this potential, it's actually negative potential, and in order to stimulate that myocyte to contract, right, actin and myosin overlay, in order to get those to contract for the heart muscle to move, you need to have this influx of sodium to start, and this propagates through. So this would be your depolarization, and then this would be your repolarization over here. You don't really need to focus on which ions affect different areas as far as what we're talking about today, but you do need to understand why you get an impulse, right? Why is it when we put stickers on somebody, we get a waveform at all? And this is the basis of it, right? This is the electrical signal that's produced within your body. And so we can also produce electrical signal by putting a battery and putting wires into the heart, or wireless, and stimulate the heart through electricity as well. But this is your body's own electricity that's created through the membrane potentials that they have. Everybody good with that? This is a must for understanding. The other part of it that I want to focus over here is that different parts of the heart have different electrical signals, essentially. So they might respond to medications or electrolytes in different ways, right? So this is the SA node, and this is the potential that's created in the SA node, AV, the Purkinjes, the atria, the bundle of His, the ventricles. So you can see they have different characteristics to them. This is a typical kind of ventricular action potential. So collectively, when we look at the entire heart, when we look at that wave of depolarization across, and you put a lead on either side of the heart, it's the collection of all those myocytes producing this kind of a wave. You put that all together and it gives you your QRS complex. Right? So that's an important thing to understand as far as where the QRS complex comes from in the first place. Okay, I alluded to this. The Pwave, first of all, represents what? It represents activation of the atria across, right, and down. And so that's a general understanding. Separate the atria and the ventricles when you're thinking about them in your head. So when you think of a P wave, when you're looking for a P wave, what you're looking for is the action potential that's created by these cells, and the atria are thin, right? They're not very thick. Actually, left ventricle, the left atrium is made up of tissue from the pulmonary veins as far as embryology is concerned. So that's basically like a big vein in a way. It has some muscle to it so that it has the ability to contract in normal rhythm. But that's the P wave, so it comes from the atria. So a wide P wave, maybe the left atrium is big. A tall P wave, maybe the right atrium is big. There's different things with a P wave that are going to change based on what's going on within the atria, but you got to understand where the P wave comes from. QRS complex, that's the ventricle, right? So activation of the ventricle, it starts with the septum through the His-Purkinje system, and it usually goes from left to right. And so this septal depolarization is represented by this Q wave in this illustration. And so the left to right activation, if you're looking from this side of the heart, over here, and the depolarization is going away from you, from the left side of the septum to the right side of the septum, and you're looking from here, then it would be a negative deflection. So that's why you get a negative deflection from that left to right depolarization of the septum, right? So again, anatomy, right atrium, right ventricle, left atrium, left ventricle, and here's the septum here, all right? It's important to understand from this depiction, you would think if I were standing here and this were my heart, that this is how it sits, but it's not even close, right? So the apex of the heart actually points out to the left, and the left atrium, the left side is actually deep to the right side, so you'd have to actually twist the heart this way and kick it up that way for it to be anatomically correct. But this basics of how the left ventricle gives you that, or the ventricles give you the QRS. This is the understanding of that. So the Q is the septal depolarization if I'm looking from this side. Now if I'm still looking from this side and I get an R wave, that's from the left ventricle being the medial part of the heart. And so most of the depolarization is going towards the left ventricle. If I'm looking from this way, then I could see here comes a wave of depolarization towards me. That's going to be a big R wave. And then the S wave has to do with further depolarization in other areas. But that's the overall reason why you get the QRS complex. T wave is repolarization. And so a cell that depolarizes has to repolarize before it can depolarize again. And so that's why you get a T wave. So again, going back, an individual cell would not give you this kind of a wave, right? It would give you that action potential that we looked at on the previous slide. The collection of these cells is what gives you the QRS complex. And understanding that where you put the stickers on the patient is going to determine what type of QRS complex you get. So if I put the sticker, the positive sticker of a lead over here, for instance, lead 1, the sticker is on the left shoulder, positive, and the negative is on the right shoulder. So if I'm looking from this side, I would expect a Q, R, and S this way. If I were to flip those, and I would start to look from the right side, and lead 1 was backwards, like limb lead reversal, I would expect the exact opposite of that. The P wave would be upside down. You would have a little R, and then a Q, and then it would come back up, and then the T wave would be inverted, right? So that's the idea that where you put the sticker determines what kind of depolarization and what kind of axis you get. All right, we'll talk a little bit more about that without going too crazy.